Good. Okay, great. I want to talk about earlier, my approach to glaucoma has changed. When I was training, we were taught to use, eye drops first, then laser, then surgery. But my approach has completely changed to earlier cataract surgery and angle surgery. Really is an initial type of approach to glaucoma. I came up with a suprachoroidal technique that I sometimes use that I've talked to you about. And my amount of trabeculectomies I've had to do is decline dramatically. But first, I want to give you a little bit of history. The cataract and glaucoma surgery started in Africa in about 2700 BC. Here you can see oculus from the Temple of Thebes at 1200 BC. You can see some of the copper needles that were used to perform couching. This is from 2700 BC. And you can see a blind harpist here from 1400 BC from the tube and knock. You can see his eyes are closed and he's blind. And here you can see also that the titles on the right are the different oculists of ancient Egypt, or the Old Kingdom from about 2600 to 2100 BC, where they had the commander of the palace oculus at the top in hieroglyphics, the chief of the palace oculus second, the palace oculus, and the oculus fourth. So there was a hierarchy in terms of eye care as well, and everything was very specialized. Now, couching is still performed today in remote parts of Africa and Nigeria. You can see here the person performing couching, and they use these copper needles to dislodge the cataract into the vitreous cavity to restore vision and visual field. And this is done out in the field. And you can see here after the cataract's been dislodged, if there's pupillary block, that's gone, okay, and the IOP would be lower. I don't think they had ability to measure or think about IOP, but that was also a side effect of the surgery. And you can see here visual restoration that took place. But we know that there are a lot of complications with this technique, and we have much better techniques today that we've evolved. I'm going to talk to you a little bit about glaucoma, which is a leading cause of irreversible blindness in the world with an estimated global burden of over 64 million people. That's projected to increase to about 111 million by 2040. And currently, the only modifiable risk factor for glaucoma is intraocular pressure. And lowering intraocular pressure is the mainstay of treatment. Now, the Baltimore Eye Study, which is a study done here in the United States, the mean normal intraocular pressure is 15. Okay? The mean intraocular pressure of patients with glaucoma is 18, not 21. Some people think, oh, if the pressure is over 21, that's glaucoma, or 25 or 30. Glaucoma really starts at much lower pressures. And so when someone has a pressure of 18 or higher, I really start looking very carefully for glaucoma in these patients. And what do you want to look for? You want to look at the optic nerve. Is there excavation, disc hemorrhage, nerve fiber layer defect over here? That's what the intraocular pressure does over time. And then what happens when you have this elevation of intraocular pressure? Well, it triggers a T cell response, okay, that leads to damage of the retinal ganglion cells. Here you see the normal retinal ganglion cells in the nerve fiber layer, and these are patients with glaucoma. These retinal ganglion cells are selectively lost due to autoimmune triggered T cell response from elevated intraocular pressure. And you can see here in animal studies that when you have elevation of intraocular pressure that takes place here, you also have elevation of CD4 counts. And then that attacks the T cells. The T cells attack the retinal ganglion cells, leading to cell death and loss of visual field. Now, lowering the intraocular pressure improves the perfusion, reduces mechanical stress, and prevents autoimmune cascade leading to the retinal ganglion cell death. So like I said, when I was training, we would treat with medications first, laser, then trabeculectomy, and subconjunctival tube shock. But why do people still go blind from glaucoma, despite all these traditional treatments? And I think that it's because glaucoma has been improperly treated, okay? You can see here, when you lower the intraocular pressure with medications, this is an untreated line in terms of progression of visual field in the early manifest glaucoma treatment study, and the treated line, you can see people still progress, okay? They progress at a slow rate, but they still progress despite a 25% drop in pressure with eye drops. What are some of the reasons for that? Some of it could be non-compliance. Non-compliance could be as high as 50% for one medication, 61% for two, 70% for multiple medications. Here's a patient trying to put eye drops in. And you'll see here that they're missing 1, 2, They get it in 3, 4, 5. They could run out of eye drops, assuming that they actually get it into their eye. The collaborative initial glaucoma treatment studies show that with surgery, you're able to better preserve the visual field compared to medications over time, particularly in advanced patients also. This is with trabeculectomy. And then the Mooresfield eye study, this is back in 1994, when they compared trabeculectomy versus laser versus medications. But the primary surgery resulted in the lowest mean intraocular pressures. The visual fields were shown to have deteriorated in patients with a medicine-treated group, and to a lesser extent in patients with a laser-treated group, but not in patients in the surgery-treated group. So they documented back then that with glaucoma surgery, there was actually no progression of the visual field. This is back in 1994. Now, the problem is that with trabeculectomy, you get a lot of complications. Within 3 years, you can get 50% complications from blood leaks, endophthalmitis, cataract formation. And that's why people have continued to use medications and laser first. But once again, surgery in advanced patients with trabeculectomy, you get better preservation of the visual field compared to medicine over time. But the thing is, this brings to what causes glaucoma in persons, particularly over the age of 50. And this is more focused to adult glaucoma, not congenital glaucoma or uveitic or neovascular glaucoma. And my observation, what I've noticed, is the enlarged lens. Over time, as you go from each decade in life, the lens in the eye increases in size. Okay, it can go from about 3.5 millimeters thick to about 4.6 millimeters. Okay, and as the lens gets larger, this starts to contribute to glaucoma. You can see how the lens gets larger. Age increased by about 30%. And over the age of 50, that's when cataracts start to form. Okay, you can see here cataract formation starts to develop and increases as you go to 6th decade and 7th decade of life. But what else happens with glaucoma? Glaucoma starts in about the 5th decade of life, goes to 6th, 7th, 8th decade. This is in all parts of the world: Asia, Africa, Europe, North America, Latin America, and all ethnic groups: Europeans, Blacks, Hispanics, and Asians. You can see glaucoma developing.
Glaucoma is a leading cause of blindness, globally affecting nearly 80 million people by 2020. This silent thief of sight involves optic nerve damage and visual field loss secondary to retinal ganglion cell damage or cell death. The eye produces fluid from the ciliary processes to bathe the eye. The fluid drains via the trabecular meshwork, aqueous veins, uveoscleral pathway, and suprachoroidal space. With time, the trabecular meshwork ages and the lens of the eye becomes larger, developing a cataract. This narrows the drainage angle, reducing the ability of aqueous to drain from the eye. Additionally, in some patients, the zonules that attach the lens to the iris rub against the posterior iris, releasing pigment that further blocks the outflow pathway. This, in addition to genetic predisposition in some patients, leads to elevated intraocular pressure. This increased pressure goes on to damage the optic nerve, described as cupping. When this occurs, medical therapy should be initiated. Since as many as 50% of patients fail medical eye drop therapy, early cataract extraction can be performed to open the angle, and goniotomy should be performed to remove the damaged trabecular meshwork to help improve aqueous flow. Patients with advanced glaucoma due to worsening outflow will need an additional intervention.
So that sort of describes, how I think glaucoma occurs in most people over the age of 50 and how we should approach it surgically. Now, this is a slide that shows the eye's conventional outflow system with the uveal meshwork, corneal scleral meshwork, just the canalicular meshwork, and Schlemm's canal. Okay, and we have to bypass. All of this gets blocked with pigment. Over time, it can be blocked by the iris, and so we have to bypass this to access the collector channels. And with cataract surgery, actually, let me back up. Schlemm's canal decreases in size with age. You can see here, as the age of a person increases, the size of Schlemm's canal decreases, okay? And why does the trabecular meshwork in Schlemm's canal get smaller? Well, one reason is the cataract also that starts to get bigger and starts to compress Schlemm's canal. And how else does an enlarging lens contribute to glaucoma? Well, here, once again, see the zonules here? These zonules rub up against the iris. When the lens gets larger, the zonules will rub up against the iris. You can see in this UBM, you see how the iris is rubbing up against the lens over here and these zonules over here? And so that's rubbing. When you look at the angle and you do gonioscopy, often you will see pigment more so in the inferior angle than the superior angle, indicating pigment liberation. Video by Dr. Gold that shows that during accommodation, the lens increases in width and you get iris rubbing. And you see the posterior boring of the iris that takes place during accommodation. And look where the zonules are. And so it's rubbing up against the lens, rubbing up against the posterior iris, and that's releasing pigment. So this also takes place as the lens increases in size. Here you can see pigment on the long zonules over here. Okay, sometimes when you look and you dilate the patient and you see pigment in zonules, that indicates that this is a prospect of pigment liberation that can block the trabecular meshwork. You can see that here as well. If you've done a laser iridotomy, sometimes you can see pigment on the behind the iris against the zonules as well. And if you look at the angle, you'll see pigment deposition in the angle here. You see on the zonules here, pigment liberation taking place and pigment in the angle. And usually this pigment in the inferior angle will be much greater than the superior angle. And this is an electron micrograph view of pigment in the trabecular meshwork as well. Now, what you want to do is preserve the dynamic activity of Schlemm's canal. This is from Murray Johnston that shows Schlemm's canal and the trabecular meshwork, and you'll see that during the cardiac cycle, there's active pumping of Schlemm's canal that takes place. Okay, this is a normal Schlemm's canal. Okay, now if someone has like mild glaucoma, you have decreased pumping of Schlemm's canal, thickened trabecular meshwork over here, and usually elevated intraocular pressure. And then in the more advanced glaucoma, you have very decreased pumping ability of Schlemm's canal and much thickened trabecular meshwork. And it's the cardiac cycle. As your heart pumps, Schlemm's canal pumps. It's a very dynamic organ. Now, trabeculectomy is the gold standard, but if you do trabeculectomy first in the patient with the lens, it will often fail. The reason for that is because that process, that pigment liberation I was talking about, will block off your trabeculectomy site. So if someone has that large lens in the eye and the pigment liberation I'm talking about, and you've done a trabeculectomy, it may have been initially successful, but over time you'll see that pigment liberation continue to occur and block off your trab site and will fail over time. So before I do a trabeculectomy, I do a lens extraction and angle surgery to open this up. And then if that doesn't work, then I'll do the trabeculectomy. There's a new Zen technology that has come out and has received a lot of press recently. And I did this publication to show that the Zen sometimes get blocked by xenons, blocked by pigment inside the eye. So when we did this technique that we described, where we exposed a failed Zen and attached it to a barbell implant to recover the use of the Zen. But the Zen, to show in our series a 40% failure rate of Zen in Black patients due to pigment obstruction. You can see here some of that inside of the pigment inside the eye that will block off the Zen as well. So I won't do a Zen until I've taken the cataract, and small Zens can get blocked because even in European patients, they have a 40% failure rate at 2 years, okay? But in Black patients in my series, it was at 1 year. So now with the cataract surgery, what happens when you've done the cataract surgery in these patients? Here's the lens, you've taken the lens out, and now you put an intraocular lens in. Look what happens, the angle is much more open. You don't have any more lens iris rubbing here. You see the iris rubbing up against the lens here? You don't have that with this very thin intraocular lens. And that's key. And that's one of the reasons why these patients tend to be a lot more stable, lower pressures, and progress less. Also, you have expansion of Schlemm's canal. I showed you before how Schlemm's canal gets smaller with age. But once you take the cataract out, Schlemm's canal can increase by 2 to 4 times over here. Okay? And that helps lower the intraocular pressure and restore outflow. So several studies have shown that by taking the cataract out, you could lower the intraocular pressure from 2 to 5 points in patients with glaucoma. An angle closure can be as much as 71% lowering the intraocular pressure. So it's very well known that cataract surgery can lower the intraocular pressure. And you can see here in this patient, I've done cataract surgery alone. Look at this vessel. I'm putting aqueous in the eye, and you're going to see improved outflow. Okay, just from cataract surgery alone, improved aqueous outflow from cataract surgery alone. And I've not done any glaucoma surgery in this particular patient. Okay. Now, there's a new device that's out, the Hydra stent, that I use a lot. I think that's the best stent for angle surgery, but it is expensive. And with cataract surgery and the Hydra stent, in their study, pre-op IOP was 26, and this came down afterwards to 16.9. But with cataract surgery alone, you can reduce intraocular pressure down to 19.2 in these patients from 26 to 19, okay? And we know that the angle closure incidence decreases, okay? This is data from England and Taiwan that shows the decreased incidence of angle closure, okay, with increase in phacoemulsification in cataract surgery, okay? So we can prevent angle closure glaucoma with earlier cataract surgery in appropriate patients as well. And the EAGLE study showed that clear lens extraction shows greater efficacy and is more cost effective than laser peripheral iridotomy and should be considered as an option for first-line treatment. So I don't even do laser iridotomy anymore. If someone has angle closure or narrow angle and I think it's occludable, I'll just take the cataract out, okay? Now, cataract surgery is not without risks. You can get suprachoroidal hemorrhage, endophthalmitis, retinal detachment, CME, corneal endothelial loss, elevated IOP, dysphotopsia, incorrect IOL power, okay? I think I've experienced all of these complications, okay? But I've done thousands of surgeries over 20 years, okay? The incidence of these complications are very, very rare, probably less than, 0.2%, but they can occur. And so you have to be vigilant, diligent to try to, enhance your cataract surgery skills to be the best cataract surgeon you could be. I do about 20 cataracts a week. And so these are very, very rare, but, they can occur and you have to be able to manage these issues. Try to prevent endophthalmitis. You can treat patients with endophthalmitis so that they don't lose vision. You can restore vision from retinal detachment. You can restore vision from CME. You can restore vision from corneal endothelial loss with corneal transplant, incorrect IOL power. All these things can be pretty much fixed and addressed, but you have to address it. And you want to try to avoid it and then address it if they do occur. So once again, my current treatment regimen has changed to more interventional glaucoma with early cataract extraction or clear lensectomy. I'll take out clear lenses too in MIGS. And then also a suprachoroidal procedure, which I'll talk about a little bit later here. And there's a variety of different glaucoma procedures, ciliary body procedures, suprachoroidal, Schlemm's canal, subconjunctival filtering. I'm going to focus a little bit on the hydrus and 23 gauge goniotomy and cyst goniotomy that's affordable that can be done in Africa. But to do this, you have to have a microscope that tilts about 45 degrees. The patient's head has to tilt 45 degrees away from you. The microscope, the optics tilt 45 degrees towards you. And a direct gonio lens, you can get them from Katina for about $25, okay, to get a direct view of the angle. And some of the stents that are out there, the one I like to use is the hydrus, okay. This has a large surface area of 53,000 square micrometers, an opening of 260 microns. There are smaller stents like the iStent and iStent Inject, but I don't like. I think they're too small for our patients. The hydrus provides the greatest outflow compared to 2 iStents or iStent Inject. You can see here, it takes up about 3 clock hours of Schlemm's canal once you insert it in properly, compared to 2 iStents here that sometimes get stuck in the trabeculum. And it scaffolds Schlemm's canal. It really opens it up for you as well. And what I don't like about the iStent is that sometimes it's so small you miss Schlemm's canal and gets buried in the trabecular meshwork. We could overshoot Schlemm's canal and trabecular meshwork. Here it overshoots as well. So although you're putting it in the TM, it's not getting in the canal per se. And studies have shown with the Horizon study that you get a better effect with the hydrus in terms of long intraocular pressure compared to iStent Inject or compared to CyPass, which was suprachoroidal. Laser, I don't like to do SLT. I think it's short-lived, and so I like to do surgery first. I only recommend SLT if a patient doesn't have access to cataract surgery or MEG surgery, maybe doesn't have access to medical therapy, then you do laser treatment in that respect to lower the pressure until they can get access to surgery. The Hydrus microstent, when you compare it to SLT, did much better. There was a 3-fold greater reduction in medication use in the Hydrus group compared to SLT, and 47% of patients were medication-free at 12 months in the Hydrus group, only 4% SLT. So the Hydrus surgery crushes SLT. This is a video from the company. Let's see.
Biocompatible,
it talks about the Hydrus.
widely used material in biomedical applications. It is a tiny, flexible drainage device that is polished to a mirror-smooth finish and is typically neither seen nor felt by the patient. The Hydrus microstent is preloaded into the ergonomic and easy-to-use Hydrus delivery system. The Hydrus delivery system utilizes a tracking wheel for microstent advancement and a proprietary interlock release mechanism for a precise implantation of the Hydrus microstent into Schlemm's canal. And because the delivery system incorporates an adjustable cannula, it can be adapted for various hand positions, including both a right-handed or left-handed implantation. The Hydrus cannula is inserted through a corneal incision at the temporal position and directed towards the trabecular meshwork, where it is positioned parallel to Schlemm's canal. Under gonioscopy, the beveled tip of the cannula should be tilted up approximately 15 degrees and then used to access Schlemm's canal through the trabecular meshwork just above the scleral spur. Please note that insufficient trabecular meshwork engagement can lead to superficial device placement in the trabecular meshwork layers. Through the trabecular meshwork, hold the cannula steady with light contact against the back wall of Schlemm's canal. Begin to deliver the Hydrus by gently rolling the tracking wheel forward while keeping the cannula tip engaged. Continue to advance the Hydrus with a slow and steady motion while gently relaxing the upward and forward pressure on the cannula. The Hydrus' highly flexible, rounded frame design provides for a smooth passage into Schlemm's canal. Observing the first window of the Hydrus as it enters Schlemm's canal will provide verification that the device is being delivered properly. You'll notice how the translucency of the trabecular meshwork causes the Hydrus to appear less shiny as it is delivered. Once satisfied with its position, the Hydrus is advanced until the microstent is released from the interlock. The Hydrus cannula is then removed from Schlemm's canal and withdrawn from the eye. If not satisfied with the Hydrus position, it can be recaptured. This can be accomplished by lining up the interlock properly and rolling the tracking wheel backwards. The Hydrus will slide easily back into the delivery system. The Hydrus microstent, a groundbreaking.
So I do a lot of these, and here's a patient with a clear lens. Okay, I've done the cataract surgery, and I'm going in with the Hydrus device. You see the pigmented obstructed trabecular meshwork, and I'm going through there. I'm inserting this device. And I'm just pushing it in a little bit more. And then after I do my irrigation aspiration, I'm putting BSS, and look at these vessels, these aqueous veins here. You see the BSS blanching the aqueous veins, restoring outflow. Okay, so instead of doing trabeculectomy, you can restore natural outflow to the aqueous veins. And it's pretty quick.
Hello, Mrs. Stroud.
Here's a patient.
I'm fine, thank you.
Okay, thank you for participating in this interview. Just want to confirm, do I have your permission to do this interview?
Yes, you do.
Okay, great. Now, you had a history of glaucoma and cataract in the right eye. About a year ago, what was it like, taking eye drops in the right eye?
It was not difficult, but a little burdensome because I had to do it twice a day, morning and night.
Okay. A few months ago, you had cataract surgery and a Hydrus stent done.
Mm-hmm.
And how's that experience been with your eye now thereafter?
The experience was good. I'm so glad I did it. And I think the one thing that I noticed most of all is that colors are so much more vivid than they used to be for me. It's been great.
And you're still taking eye drops in the right eye?
No, only in the left eye.
So the pressure's under control.
Yes.
Do you know what your pressures were before the surgery on eye drops and after the surgery on eye drops?
I know, I remember numbers like high teens to low 20s. And now it's today, I had, what, 10 in this eye? So it's much better.
Okay, great. Thank you so much for sharing your story.
Sure, my pleasure.
So we described the use of trypan blue to look at the aqueous veins after Cahook goniotomy and to see improved outflow through the aqueous veins. And you can see here trypan blue use after the hydrous stent to produce improvement of aqueous outflow with the hydrous stent.
Mr. Njai, thank
Here's
you
another
for
patient
agreeing to do
testimony.
this video. Do I have permission to do a video with you right now today?
Yes.
Thank you so much. Now, you have a history of glaucoma and you've had cataract surgery in both eyes with a hydrous stent in both eyes.
Yes.
And today you come back for a follow-up visit several months after the surgery, and your pressures were noted to be 11 and 12 on no eye drops. Can you tell us what it was like before when you had to take eye drops for glaucoma compared to now, please?
Well, it wasn't very convenient having to do it every night before I went to bed. So now that I don't have to do it, it really makes things look a little bit easier.
Okay, great. And how's your vision after the cataract surgery?
A lot better.
Okay, great. Thank you so much, sir.
Sure thing.
Now, this is a publication from our initial series on the real world efficacy of hydrous microstent in Black and Afro-Latino patients with glaucoma, retrospective study. And in all patients that I saw, 72% at 6 months did not need eye drops, okay? It was a little bit higher in people with mild glaucoma, 85% did not need eye drops. And people that had advanced glaucoma, 50% did not need eye drops, but 50% did also need some eye drops. So the more advanced, the earlier you can get it done in glaucoma, the better. We also reported clear lensectomy, goniosynechiolysis, and a hydrous microstent, and mixed mechanism glaucoma, because usually in America, people wait till the cataracts are 2040, but I find that a lot of times people have 2020, 2025, 2030 cataracts, and they benefit from this for their glaucoma as well, and we should not wait till the cataract gets to 2040, in my opinion. Here's a Cahook blade. This device is less expensive. The hydrous stent costs about $1,000 or $1,200. The Cahook blade costs about $450. And here you could perform a Cahook goniotomy that just removes the trabecular meshwork and inner wall of Schlemm's canal. So this is less expensive than the hydrous stent, but still pretty expensive for Africa at $450. I think the company does make lower price for Africa. Here you see blood reflux, which is normal from the aqueous veins that takes place. And here I'm doing irrigation, and you see blanching of these vessels over here, indicating reconnection of aqueous outflow to the aqueous veins. And here's an angle photo after Cahook goniotomy. You see exposure of Schlemm's canal, and here removal of the inner wall of Schlemm's canal and trabecular meshwork. And here you can see excision. This is a histology showing excision of the inner wall of Schlemm's canal and trabecular meshwork. And this is data just showing that with Cahook goniotomy and cataract surgery, you have excellent lowering of intraocular pressure to the low teens that can occur. But is there a low-cost option for microinvasive glaucoma options for resource-poor areas? Okay, first, I want to talk about small incision cataract surgery.
As this is a brown cataract with a large nucleus, I have made a larger peritoneum and also I have made a larger section. So you can see I have first created a groove that is about half thickness deep, and then I create a plane in that groove that will allow me to dissect forward. The dissection up to the sclera is carried out following the scleral curvature, but at the limbus, in order to follow the corneal curvature, the plane is angled up further. A side port in the horizontal quadrant allows a rexus to be carried out easily and also gives access to the sub-SICS tunnel for cortex aspiration. It also allows access into the anterior chamber for all maneuvers to be carried out in a closed chamber manner. A larger than normal rhexis is made to allow prolapsing the nucleus out, and as you can see, I have also made 2 or 3 relaxing incisions in the superior rhexis. A horizontal entry is then made into the anterior chamber all along the length of the tunnel, and the internal lip, as you can see, is larger than the external lip. Hydrodissection is then done to prolapse one pole of the nucleus out, and viscoelastic is injected both below and above the nucleus in order to protect the endothelium. Once this is done, the nucleus is dialed out to bring it out into the anterior chamber. The superior rectus brittle suture is pulled slightly upwards while at the same time injecting viscoelastic under the nucleus, and this allows the nucleus to be brought out through the corneoscleral tunnel. Sutures are then taken and the viscoelastic is washed out. Cortex aspiration is then done through the side port, maintaining a formed anterior chamber, and this is the advantage of the side port. It also allows you access to the sub-tunnel cortex very easily. The relaxing incisions made in the rhexis can be seen clearly here. Now, viscoelastic is again filled in the anterior chamber, and the IOL is inserted. It can just be placed into the bag, and the trailing haptic can be dialed in using a dialer. The side port again allows good maintenance of the anterior chamber during these maneuvers. Viscoelastic is finally removed using the Simcoe cannula, and stromal hydration of the side port is done using VSS. It's easy to close the conjunctiva over the tunnel by cauterizing the edges together. As you can see, small incision cataract surgery gives very good results and a very clear cornea in even brown cataract.
So I do phaco in the United States, but this small incision technique is a much more affordable option. In Nigeria, I know at the Eye Foundation Hospital, they've got the numbers down to the cost being about $25 to do this type of cataract surgery. And then at the end of the case, when you're doing this, you can fill the eye with viscoelastic. And if you have the proper microscope, then you could do angle surgery as well. And we reported a novel, low-cost, effective technique in using a 23 gauge straight cystotome to perform goniotomy, making microinvasive glaucoma surgery accessible to the Africans in the diaspora. Because of the economic inequalities we have in the United States, in the Caribbean, and in Africa, we can't afford, in the United States, all the research is trying to come up with these expensive devices to make billions of dollars for companies on Wall Street. But we have to think outside the box to come up with cost-effective options to treat people in our communities. And then with this lens also, this is a box of 10 gonio lenses. These are like $25 each. They're disposable. This is quite affordable. And when you use one of these gonio lenses, you could probably sterilize or alcohol for a day and do several cases as well. These are the bent 23 gauge cystotomes that I use. A box of 10 cystotomes is about $40. And I order them from Louise Singer at Eagle Labs. They come pre-bent already. And this is what it looks like, the cystotome, okay, similar to like a Cahook blade. These cystotomes cost about $4. And you can see here, you can perform a goniotomy, an excisional goniotomy, and get blood reflux here. And you can see here, this is a 23 gauge cystotome that I'm using to perform goniotomy with a disposable gonio lens. And the toughest part is just getting the positioning and getting the view of the patient. That gets better with time as you practice. And I'm opening up the trabecular meshwork and inner wall of Schlimm's canal, similar to a hook goniotomy. This patient's had a previous failed trabeculectomy that was sent to me, and I did cataract surgery, and now I'm doing the goniotomy portion. And here I'm using a cystotome. This is a 23 gauge, and you can also use a Sinskey hook, and I'll show you that in a moment. Just like a Sinskey hook, I'm going in now that Schlimm's canal is open. If you have an MVR blade, and I'm going to go the other way with a Sinskey hook and unroof Schlimm's canal there. Boom. It just opens it up just like that. Okay. You have about 4 or 5 clock hours that are open. You have blood reflux there, and you've restored aqueous outflow to the collector channels. You can see here, before irrigation and after irrigation, you have blanching of the vessels that occur. There's one group out of Washington University that also reported a small study with a bent needle goniotomy and showed that pre-op IOP was 17.8 on 1.6 medications, and post-op 6 months, intraocular pressure decreased to 14 on 1.6 medications. We taught this technique in Ethiopia with Dr. Biba Georges and her glaucoma team at the Menelek Eye Hospital. Jonathan Pons from Swaziland We taught him this technique, and he felt that the cystotomes were excellent and similar to the Cahook, because he was used to using the Cahook, but he didn't like spending all that money, $450 for each, compared to $4 for the cystotome. So we're trying to spread the use of this surgery more affordable. Next thing I want to talk to you about is the suprachoroidal microtube technique. Okay, there was previously a CyPass shunt that was on the market in terms of suprachoroidal devices, but that got pulled because it caused corneal edema. There's the iStent Super that's not approved. There's the Gold shunt that was under research study. There's the mini inject, excuse me, that's under a study in Belgium right now, but it's not available. And I came up with this suprachoroidal technique where we take a silicone tubing, place it behind the iris in front of the IOL to the suprachoroidal space. And this works well to lower intraocular pressure. The suprachoroidal space has a 4 millimeter millimeter mercury pressure differential. And it's also, in the United States, we use prostaglandins first line that affects treatment to the uveoscleral pathway. And this, for those of you who have not seen the CyPass, this is how the CyPass would be done. After cataract surgery, we place this device inside the eye under gonioscopic guidance. This is Dr. Anchelev, who was the inventor of the CyPass technique. And we would insert the CyPass into the scleral spur with this device, and then we would release it. And it worked really well to lower the intraocular pressure. I was really liking it, but it got pulled off the market because the part that was sticking out, I'll show you here. This part that was sticking out would cause corneal edema over a period of time. And so they pulled the device off the market. The iStent Super is not available. So I came up with this technique to place the tube instead over here next to the cornea, behind the iris over here, so that you can still get lowering of intraocular pressure. And we published a study of our initial case series that showed 36% intraocular pressure reduction at 3 months, and the amount of glaucoma medications per patient at 3 months dropped from an average of 3 to 0.25. And this tubing can come from the Ahmed valve tubing, barbell tubing, it's 300 microns in opening, and the Oral Lab, which is the least expensive, it's $50 US available. You can use this silicone tubing, sterile tubing as well. In the United States, I use the tube extender from New World Medical for the silicone tubing. These are all devices
Laroche
approved for
is a
intraocular use.
ophthalmologist
This is a video that shows
and president
how to do
of
the
Advanced
procedure.
Eye Care of New York. He is a graduate of New York University and Cornell University Medical College and inventor of the intrascleral ciliary sulcus suprachoroidal microtube technique, a surgical treatment for glaucoma. This microtube shunt procedure should only be used in patients with glaucoma whom have had their cataracts removed. This procedure allows aqueous fluid to safely drain to the suprachoroidal space without the risk of corneal edema, which can occur when a tube is placed in the anterior chamber. Under local anesthesia, an inferotemporal conjunctival opening is made to place the microtube in this quadrant. A small partial thickness scleral flap is made to place the tube. A micro opening is made superiorly to place a viscoelastic gel into the eye to expand the space between the posterior iris and the intraocular lens. This is where the silicone microtube will be positioned. A small 23-gauge needle is used to make an incision into the ciliary sulcus. Then the silicone microtube is placed. The position is confirmed with a second instrument. The microtube is then tied to the eye. Then another micro opening is made to access the suprachoroidal space. The posterior end of the tube is inserted into the suprachoroidal space. This connection allows the aqueous to drain to the suprachoroidal space. This bypasses the damaged trabecular meshwork to successfully lower intraocular pressure. The scleral flap is then sutured closed. The viscoelastic gel is left in the anterior chamber. Post-operative steroids and antibiotics should be given. Dr. Laroche has had excellent results lowering the intraocular pressure. Since glaucoma is a lifelong disease that can worsen with age, a patient's intraocular pressure should still be checked periodically. Additional medical therapy or repeat surgery may be needed. Diet, exercise, and mindfulness are important aspects for glaucoma care as well.
So with this video, the bevel of the tube in this video was facing the iris. I cut the bevel to be away from the iris towards the intraocular lens. And with the suture, I pass the suture through the tube to the sclera, not around it because I don't want the tube to move. So it's just a slight modification from the video. And in our initial 26 patients, 18 patients were very successful at 12 months, with a mean pre-op IOP was 21 on 4.2 medications, and mean post-IOP 12 on 2.4 medications. Patients will still need medications with this technique as well, I find. It's not as IOP lowering as trabeculectomy, but you do get less complications in trabeculectomy. You can get blocking of the tube, which we had about 4 people that had blocked tubes treated with laser iridotomy. You can get scarring of the suprachoroidal space. 4 patients did need additional surgery. When I leave viscoelastic in the eyes to prevent hypotony, you're going to get hypotony for the first week. The eye has to autoregulate. So I do leave the viscoelastic in the eye. And you can see IOP spikes. I mean, these patients can do well for 6 months, 12 months, but then they can get like a pressure spike that can occur if they're scarring the suprachoroidal space. So you do have to surveil these patients. But it's an inexpensive way to offer suprachoroidal surgery compared to expensive devices like the CyPass that cost $1,000. This silicone tubing is like $50. Here's a UBM showing the silicone tubing and ciliary sulcus to the suprachoroidal space. Here you see the tube with the UBM here. Here you see aqueous outflow in the suprachoroidal space. Tubing here in the ciliary sulcus going to the suprachoroidal space here. This was a tube that was blocked by the iris, and I did a laser iridotomy that removed that blockage there. And here's another UBM showing the suprachoroidal aqueous in the suprachoroidal space here. And what I do now also in patients with advanced glaucoma, I'll combine the suprachoroidal technique with the goniotomy. I'll do both to improve aqueous outflow through aqueous veins and the suprachoroidal technique. And so far I've done that in about 6 patients, mean pre-op IOP 21 on 4.3 medications. At 6 months, mean IOP is down to 13.5 on 0.83 medications. Long term, you do have to watch out for tube obstruction or IOP spikes. You don't get a bleb, and the risk of benefits are similar to glaucoma surgery. And this is how I do it. These are patients that are pseudophakic. They've already had cataract surgery. And this is a 23 gauge cystotome. And first I'll do the goniotomy and open up the outflow via Schlemm's canal, removing trabecular meshwork and inner wall of Schlemm's canal. And with the cystotome, I put on viscoelastics. You could always deepen the anterior chamber while you're inside the eye because the cystotome is on the viscoelastic. And here I'm using a Sinskey hook also to do the other side here. You can put a Sinskey hook here. You can use the same needle. And here I'm just showing you, you can use both to open up Schlemm's canal. Okay. And then I'll put a stitch through the wound and lift the viscoelastic in the eye. And then I'm sitting temporally here, and I'm doing a conjunctival dissection to create a conjunctival peritomy. And this would be in the infratemporal quadrant. Here I'm giving some subconjunctival injection of 2% xylocaine, 0.75% marcaine. You do give, normally in my cataract surgery and hydrus, I do under topical anesthesia or intracameral anesthesia. But for this procedure, I do have to give a peribubble block because they will feel some of the dissection. This is an atovicral corneal retraction suture I'm just passing through there to retract the globe upwards to give me exposure. Then I'll dissect about a 4mm by 4mm scleral flap with a hinge. And this total procedure time takes about 30 minutes or so. It's going to be a little animated. I cut it to make it quicker here. Here I've done the scleral flap. And I'm creating an incision in the cornea. I'm going to place viscoelastic now inside the eye. behind the iris in front of the intraocular lens. I'm just repositioning the IOL. I thought the IOL was a little bit superior, so I just pushed it back more centered. Moise, your baby's crying, Moise. Cutting the tube here. Moise, you got to mute yourself. And I'm 23 gauge needle. I'm placing it. Thank you, Moise. 23 gauge needle now into the ciliary sulcus that I've dilated with the viscoelastic. Okay. And I cut the bevel of the tube. This is a tube extender I'm using. Like I said, you could use the Oralab tube, silicone tube, it's the same size, about 300 micron internal diameter. And I placed the tube into the ciliary sulcus. And I'll see it come out behind the iris here. And you see it there. And then I'll retract it a little bit because I don't want it into the visual axis. So I'll just pull it back a little bit. The patient's dilated for this procedure. Now, I take a tenoproline suture because proline is longer acting than nylon. This is a tenoproline, and you see I'm tying it, passing it through the tube to the sclera, tying it down. And I'll do a 3-1-1 knot. And I'll cut that. So that tube's not going to go anywhere. It's not going to move. The proline suture is going to last for years. So now I'm going to cut down the suprachoroidal space. Okay, and here with the crescent blade, I gently cut down to the suprachoroidal space. It's a true 30 micron space between the sclera and the choroid. And I gently cut down, and you see I'm there. And I'm going to cut the tube a couple of millimeters. Flush. And I'm going to insert the other end of the tube into the suprachoroidal space. And then I'm going to just close my flap. And I tie the flap down with 2 interrupted vicral sutures, and I close the conjunctival peritomy. What's nice about this procedure is that the patients don't have a bleb. You don't have to worry about blebitis or endophthalmitis, and they usually have pretty good visual recovery after about a week, 7 to 14 days. And so we've published this technique also, and this is a patient with osteogenesis imperfecta that had thin conjunctiva. And what we did, we added a corneal patch here. You can see how the tube appears at 6 months in the suprachoroidal space. We taught this technique in Nigeria with Dr. Gunro and her team at the Eye Foundation Hospital. We taught this technique in Haiti also, Dr. Mike Mangre and Dr. Pierre De Castro. And many of these patients will not need trabeculectomy. They can either be controlled with medications, maybe 1 or 2 drops, and still get low pressures like the 12 to 13 without a trabeculectomy. So what I do, this is my initial approach to glaucoma that I do. And then for trabeculectomy, I'm not going to talk about that here because that's like a whole separate lecture. Dr. Leon Herndon of Duke University has an excellent video series on both trabeculectomy and tube shunts for more advanced patients. I wanted to focus on affordable options that you guys can do in Kigali and Rwanda. Tubes can be a lot more expensive. The trabs can work well, but sometimes if you have poor patients going to conditions that are not hygienic or out in the fields or work area, there's a high risk of endophthalmitis and complications. So I wanted to share those with you. But please, you can reach out to Dr. Herndon to get his video lecture series on trabeculectomy and tube shunts. I think it's excellent. So in conclusion, cataract surgery and angle surgery is cure, decrease rates of blindness, and avoid complications. Ciliary space, because of its anatomical and physiological characteristics, and attractive and suitable pathway can be exploited by glaucoma surgeries. But with the suprachoroidal space, that's not a perfect answer. Although I've gotten some great results in some people, some people have had pressure spikes, needing a lot of medications and or surgery thereafter. So we still have to find a way to optimize that as well. Thank you.
Wow. Thank you so much.
Any
So
questions?
are you willing to take questions, Dr.
Yeah,
Laroche?
yeah, I'm okay. Actually, I'm surprised I finished it in 15 minutes, but that's good. Yeah, we definitely can take questions. Let me close out of this.
Okay.
Okay.
So yeah, you can see that we got more participants as you were talking.
Yes.
That was really excellent. Thank you so much for that. So the suprachoroidal technique, you only do it in pseudophakic patients?
Only pseudophakic patients, because I didn't want to put the tube in the anterior chamber in front of the iris because
Yeah.
of what happened with the side passage, the corneal edema.
Yeah.
And we know that. So I only want to do it. And then in my mind, usually the lens is the cause of the glaucoma. So I want to get rid of that. And I want to do the goniotomy first. So I like to do those first. Or sometimes I've done combination. Actually, we have a couple of patients where I've done all three: cataract surgery, goniotomy, and a suprachoroidal tube in advanced patients. And we're going to do a report on that also. So in advanced glaucoma patients, I'll do all three: the cataract extraction, the goniotomy, and the suprachoroidal tube. And let's see how that works first. And then if they need it, then I'll do the trabeculectomy if they need it. So that's my approach in those patients.
Thank you. So residents, please be thinking of any questions that you'd like to ask, and I'll ask my second question as they get ready. So in my previous life in Kenya, where the health system was not like Rwanda, where the community insurance allows patients to top up their glaucoma medication, surgery was my first line of intervention because there was just very little access to medication. And it was not such an accepted procedure by my colleagues, but based on my experience with patients, I was really happy that I felt I have intervened, and I'm sure I have intervened for this patient. And if he goes back to the depths of Turkana and I never ever see him again, at least I've done something for him. So it was quite interesting to hear that your thinking is that surgery should be offered more often.
Well, not only more often, but it should be offered first. And what's nice about it is that the fact that nowadays with cataract surgery is in the United States is very safe, okay? And everyone over 50 is having difficulty reading. They need glasses to read. And it's an opportunity to improve their vision, improve their near vision by getting into -1 or giving them a multifocal lens. And if they have the means to pay for multifocal lens so they don't need glasses, you can really improve their vision and lower their pressure, okay? Before with trabeculectomy, we know that 30% of people after a few years are gonna get cataract. You're gonna lose 1 or 2 lines of vision. And that was always like the bad thing about glaucoma surgery. Oh, you're gonna lose vision, you're gonna get this and that, astigmatism and this. But now with this, you could say, oh no, we're gonna improve your vision and make you see better clear without glasses, get rid of the yellowness from the cataract. Because even a 20/20 cataract in a 50-year-old, there's still some yellowness or haziness there. Because even the patients, when you take it out, they say, oh, I see much better, I see much clearer, I see much brighter. Oh, I don't need glasses as much, I can read without my glasses. If you get them to -1 or -1.5. So we can improve vision with this and lower the intraocular pressure. And many patients not even need to use eye drops. Some may still need eye drops. And then some, those that are more advanced may still need trabeculectomy. But once you do this and once you master this, the patients will come, because the patients will tell their family members who may also have glaucoma. They'll talk to other people in the community. Oh, I know a good doctor. I see better. I know I'm not on eye drops. And the patients will flood your practice in that respect. So the key is getting good surgical outcomes, okay? And, being excellent at your cataract surgery, and then eventually becoming excellent at the angle surgery, and and or the suprachoroidal surgery if you do it, and or trabeculectomy. And then you see what works for you, what doesn't work for you, what you like, what you don't like, and depending on the environment and what you're comfortable with your skill set.
Thank you. So Dr. Omar has joined us. He's a fellow who's been with us from the Wills Global Ophthalmology Program. And one of his tasks has been to teach the residents how to do gonioscopy. So Omar, how is that going? Because now the residents can see why we insist on these techniques, because they impact your surgical career.
Well, first of all, thank you so much, Dr. Laroche. That was fantastic. But yeah, what Dr. Chiku's saying, it was interesting. I mean, as it always is, teaching residents about the angle, because you learn about it in textbooks, but to actually visualize it and then even go further to imagine manipulating the angle, I think is interesting, because it's like this this new way of approaching glaucoma. It's something that I think we can learn about in books as much as you want, but until you actually are in the angle and seeing how you can improve people's glaucoma, I think that's fantastic. And your videos were great too. I'm sure the residents all benefited from it.
Well, gonioscopy is essential. I mean, the first thing I do if I'm evaluating a patient for glaucoma is gonioscopy. You've got to look inside the eye and look at the angle and see the trabecular meshwork. Can you see it? How does it look? Is the iris blocking it? Is it a lot of pigment blocking it? Is there neovascularization? You have to look to see what's going on. If you can't see the angle, if you're not done gonioscopy, you may not know how to approach that patient. Okay?
Right.
And so, or explain the type of glaucoma, explain what the mechanism is. So I have a whole separate lecture on gonioscopy, and if you want, we can do that lecture too someday. But that's extremely important, to have that. And one of the reasons why I propose surgery first is because of the lack of gonioscopy. I mean, even in the United States, half of the doctors don't even do gonioscopy. So, and a lot of those people have angle closure. So if you do cataract surgery and angle surgery first, you'll treat, a lot of those people appropriately without knowing it, because you didn't look at the angle or pick up the angle closure. So that's why, as long as it's not neovascular glaucoma, uveitic glaucoma, but you would like to see it and explain to the patient. And a lot of the pictures that, like you see these pictures over here behind me? I have these pictures, and I'll show the patient, oh, this is what your angle looks like. This is what we're going to do before surgery, after surgery, boom, boom, boom. And once the patient sees that, they get it. And they're like, okay, yes, I don't want my angle to be like that. I want it to be like this. And yes, okay, I'll go for the surgery. And so that's how I explain that to them. And I like the Hydra stent, I do about 5 of those a week. I do about 10 cataracts to help prevent or treat early lens-related glaucoma. You want to see the pigment in the angle. You want to see if the angle's pretty wide open or narrowing. Because if I start to see narrowing of the angle, the pressure's 18 or 19, patient has a family history of blindness or glaucoma, I say, you know what, you're having the early signs of narrowing of the angle with elevation and pressure, and large lenses contributing to that. I want you to know that we will need to probably take that cataract out at some point to help prevent glaucoma, and this will help make a big difference for you. And if I want to, at the same time, I'll do a goniotomy as well. So gonioscopy is crucial. So you have to learn gonioscopy, buy a gonio lens. It's an investment into your future, and you should gonio every patient with glaucoma until you know how to do it right. And then also the Iowa. There's a gonioscopy course by Wallace Alward on the University of Iowa website. I think it's gonioscopy.org. It's an excellent teaching program, how to do gonioscopy by Wallace Alward, www.gonioscopy.org, I believe.
We've been watching a few of those videos. I always find it's a really great place to start when you're teaching about gonioscopy, to watch the videos first. I think he does a fantastic job of explaining things. Well, I do have a question about your...
Okay, good.
I do have a question about your procedure. It's so interesting. But as a young surgeon, seeing that procedure, I immediately started thinking about the depth of your blade and, the fear that I would go too deep. Did you have any, what was the incidence of suprachoroidal hemorrhage when doing your procedure?
I didn't have any suprachoroidal hemorrhage.
You didn't have any? Interesting.
No. I use a 69. The suprachoroidal space is a real space. And the choroid is spongy, if you ever back there and you take a Sinski hook and you touch it, it's like a little spongy type of thing. And it's not like I'm saying I play with it too much. I touch it because it's very vascular and you get little hemorrhage. But if you just go with your blade until you just get through, and I use a 60 crescent blade, that's what I'm applying.
So it's less of a visual confirmation and more of like a palpable tactical.
Yeah, more powerful.
Tactile.
Exactly.
I see.
Now you gotta have good hands and go down there gently. And, if you got rough hands, you're like boom. With a blade, you could create a problem. So you gotta have good hands to do that. But I'm glad to see you teaching in Africa, Omar. But in Philadelphia, in your part of the town, there is a lot of residential segregation where whites live over here and blacks live over here. And at the Wills program, they've trained very few black residents. And so when you go back to Wills, you let them know they got to train a lot more black residents to deal with the glaucoma in the community, okay?
No, you're absolutely right. That's one of our global program, one of our projects is to increase our presence in Philadelphia as well. So, and I appreciate you saying that.
But got to train more black residents, man. You got to train more black residents. They should be training about 2 a year. So take that to your leadership over there from Dr. Laroche and Kigali in Rwanda.
I'll send the message.
Okay.
Thank you very much, Dr. Laroche. And my residents are all very shy, but I'm going to ask Amani. Amani, if you can hear us, could you just thank the speaker? And if you can, give us your impression about the lecture, and then we'll release Dr. Laroche because I know patients are waiting. It's actually very hard to get an appointment with him because he now has a long, long waiting list. So Amani?
Yes, Prof, thank you for this opportunity. And thank you, Dr. Laroche, for this great lecture. Actually, we've been reading in books those microtubes, but we actually not had a chance to see someone who is doing it in real life. So it was a great lecture with those different procedures. So for me, most of the procedures I have never seen them, but it is very interesting to see how they are done based on the videos that you showed us. And you were somehow slow so that we also who are starting to see those procedures, we understand well different steps. So I'm very happy to attend this lecture. I hope, as you said, that you have other lecturers like the conioscopies or others. I hope we have another chance to see you again in another lecture. So thank you so much, sir.
Okay, thank you for those kind words. My challenge to the residents is to really try to hone in on your surgical skills to be excellent small incision cataract surgery without any complications, with perfection. That will get better as you do more over time. And really focus on doing like a perfect cataract. And by doing that, the patient's going to be happy. And when they're happy, the word's going to get out. You guys are doing great surgery, and they'll send other people in. And at the same time, you're doing angle surgery, learning how to do that and visualizing an angle, ordering these lenses from Katina, which is not very expensive, or investing. You should invest in a gonio lens and gonioscopy lens and direct gonio lens also that you can use in your OR. You can use reusable gonio lenses. Those are a little more expensive, about $500. The disposable ones are about $24. And then, because there's a huge need to train more surgeons, particularly in Africa, in all the sub-Saharan countries in Africa, because this cataract and glaucoma issue is a big issue over there. And it's all related to the mechanisms that I've described. Because I've traveled to the Caribbean, I've traveled to several countries in Africa. When I've examined patients, this is what I'm seeing over and over and over again. And so it's a different type of glaucoma. When we present with glaucoma, we come in with severe visual field defect, mean deviation -7 compared to Caucasians, where in the United States and Africa, United States and England, where there are a lot of eye doctors, when they present with glaucoma, maybe it's like ocular hypertension, or a small visual field defect. So earlier surgical intervention is going to be crucial to make a difference in bending curve of blindness. And we need to train a lot more surgeons, African surgeons in Africa, Caribbean surgeons, and Caribbean and Black surgeons in the United States, because we still have a lot of residential segregation in the United States. Where every major city you go to railroad tracks, you'll see white folks predominantly over here and Black folks predominantly over there. So we still have those challenges to overcome. But it's been a pleasure.
Thank you, sir.
Thank you.
Thanks, Dr. Laroche.
All right, Omar. Okay, Siko.
Yes, thank you so much. And I'll be calling on you frequently.
Well, yeah, Siko has my email. If you ever have any questions, you want to email me about something, feel free to email me. But I'm counting on you guys. Next time I speak to you, you're going to be experts on gonioscopy. You'll have ordered the angle devices. So after you've done extra cap surgery, you practice looking at the angle just so you can visualize it. You know, hopefully you get that microscope that tilts. Okay, so these are the things I'm challenging you to get going to the next step. All right. All right.
Bye.
Take care now. Bye-bye.
Yeah. Bye, everybody. Stay safe.